What is the format of the meeting? Hmm? My voice, you remove my voice, my face. Okay. When it's still, my voice is on now.
Colleagues, a very good afternoon to you. Thank you once again for joining the World Health Organization Africa Region's COVID-19 online briefing. We have been having these the past few weeks now, so welcome. Thank you so much for joining us. So today, we'll be talking about COVID-19 and health work infections in Africa. As you know, I think the WHO has said about 1 in 10 healthcare workers will get infected by COVID-19, and they're the most physically and psychologically vulnerable and impacted by COVID-19. So before I introduce you to our esteemed panel, a very good afternoon to you once again. I'm Tsipiso Makwet. I'll be moderating these sections for you. Just a quick look at house rules. Remember that please, you have to use the Q&A function of the Zoom app if you want to ask questions. We'll be asking you to also introduce yourself and the organization which you're representing at this briefing. And a reminder that this briefing is also going to be broadcast in dual translation, that's English and French. So all you have to do is go to the icon at the bottom of the app, it's like a globe icon, and then you choose your preferred language. So you'll be able to hear both English and French translations. Francois?
Bonjour et merci de vous être connectés pour cette conférence de presse. Donc pour entendre le son en français, vous devez aller dans les options de Zoom, l'option interprétation qui ressemble à un petit globe. Et si vous cliquez sur français, vous pourrez entendre l'intégralité de la conférence de presse en français. Merci.
Thank you, Francois. So joining us for this panel discussion is Dr. Matsidi Somwetu, who is the WHO Regional Director for Africa. She is in Congo-Brazzaville. In Ouagadougou, we're joined by Honorable Dr. Leonie Claudine Logui, Minister of Health in Burkina Faso. The Honorable Dr. Alpha Ouari is the Minister of Health and Population of Sierra Leone, joining us from Freetown. Welcome to you as well. Dr. Jamima Dennis Antwi is the International Maternal Health and Midwifery Specialist. She joins us from Accra, Ghana. And just as a reminder that, as usual, we are joined in Congo, Brazzaville by Dr. Michel Yao, who's the WHO Emergency Operations Manager. He's on hand to answer any of the questions that we have. So without further ado, let me please invite to the panel to speak Dr. Moeti. Dr. Moeti.
Okay, thank you very much, Tsepiso. And good morning, good afternoon to all our colleagues from the press who are joining us. It's my great pleasure to be joined today by the Honorable Minister of Health of Burkina Faso, Dr. Leonie Claudine Log. Bonjour, Claudine. The Honorable Minister of Health and Population of Sierra Leone, Dr. Alpha Wurie. Welcome, ministers. Thank you so much for having made time to join us today. And I would also like to welcome Dr. Jemima Dennis Antwi, who is an international maternal health and midwifery specialist joining us from Ghana. So together, we'll be discussing how COVID-19 is affecting health workers who take care of all of us, who provide treatment and care and make sure that even if we get ill with the virus, we minimize the number of people who get seriously ill and who die. Then in addition to doing that, they have a heightened risk of getting infected with COVID-19. They also have concerns about taking the virus home. They also suffer psychological pressures from working around the clock. We have seen in countries where the situation is how hard the healthcare workers are. It is and discrimination because of fear, misinformation around this virus. Does work for important contribution that they make. They protect us. And so too, we as people and the national authorities should protect healthcare workers. And I'm sure that the honorable ministers will share with us how this is being done in their countries. In the African region, more than 10,000 health workers have been infected with COVID-19. One of the biggest challenges in protecting health workers has been the global shortage of personal protective equipment, which has severely affected countries on the continent. Through the global UN supply platform, more than 2 million items of PPE, including masks, goggles, and gloves, have been shipped to African countries, and 41 million PPE items are in the pipeline for shipment starting this weekend. We are committed in WHO, with the support of international partners, to continue helping countries to replenish these essential supplies. Turning then to the COVID-19 situation, countries have continued to ease restrictions on people moving and gathering. And we have seen that now on the continent, there are almost 770,000 reported cases and more than 16,000 people who have died of COVID-19. In the WHO African region, which is mainly sub-Saharan Africa, we have had more than 115,000 cases in the past week, and 93% of these occurred in 10 countries, including over 74%, so almost 3/4 coming from South Africa. Cases have also increased in Southern African countries such as Zambia, Zimbabwe, and Namibia. And we see that, however, 12 countries have remained at having fewer than 1,000 cases. In Africa, world, there is very robust debate and decision-making happening as countries and governments have to balance public health and the social measures put in place with opening up the economies, opening schools and businesses. This easing of measures now demands a really strong focus on prevention through strengthened public health systems and action by communities. I'd like to end by reiterating our call for global solidarity and equitable access to essential supplies in fighting COVID-19, including personal protective equipment, test kits, and other critical items. There are urgent and continuous needs for support from the international community as African countries respond to this crisis. Finally, I'd like to mention that this week, WHO and the Africa CDC launched an expert advisory committee to provide independent scientific advice and support to countries on research and development of traditional medicines and remedies for COVID-19. I very much look forward to today's discussion and thank everyone so much for joining us.
Thank you very much, Dr. Muhyiddin. And just by the way, colleagues, I'm sure wherever you are, you may be getting a break in transmission. We know this is what happens. We're in those times. Unfortunately, technology isn't always as reliable as we'd like. So please do bear with us if there is that break in transmission. So without further ado, let me then now get some perspective from the Honorable Dr. Leonie Claudine Lobu of Minister of Health of Burkina Faso to just give us a sense of what the COVID-19 situation with regards to healthcare workers in Ouagadougou is. So let's hand over to you, Dr. Lobu. Dr. Lagou?
Ok. Merci. Merci. Je voudrais dire bonjour à tous ceux qui sont là, honorable ministre Alpha et la directrice Afro de l'OMS et docteur Jemina et tous ceux qui nous accompagnent pour cette conférence qui nous permet de partager nos expériences. Il faut dire que je vais présenter ma communication par PowerPoint pour que vous puissiez suivre. Il faut dire que le personnel de santé a joué un rôle essentiel dans les résultats d'étape auxquels nous sommes parvenus au Burkina Faso. Et ces temps-ci, dès le départ, ce personnel a été là pour la prise en charge des patients, pour la prévention et le contrôle de l'infection, pour la surveillance. Et pour cela, ce personnel de santé devrait comprendre la dynamique de transmission du virus parce que dès le départ, il y avait la psychose générale. On a cru que SARS-CoV-2 était Ebola et tout le monde avait peur. Donc, il fallait former les agents de santé à se protéger afin d'éviter une contagion. Et suivant par là. Et cela a été possible et depuis l'annonce de nos cas, le 9 mars, nous avons fait la rencontre de 2 cas qui étaient des alertes. Et ces 2 cas avaient déjà permis de savoir que nous avions des difficultés, nous allions avoir des difficultés en ce qui concerne la sécurité du personnel. Et cette sécurité a pourtant été une priorité pour le gouvernement et une priorité pour le chef de l'État et le ministère de la Santé. Avant de continuer à cette étape mes propos, je voudrais dire qu'au 19 juillet, voilà comment se présente l'épidémie au Burkina Faso. Depuis le 9 mars, date à laquelle nous avons fait la connaissance de nos 2 cas, du virus par 2 cas importés, 2 cas qui venaient de la France. Nous sommes à 1065 cas aujourd'hui, donc 53 décès. Mais il faut souligner que depuis environ 2 mois, nous n'avons plus de décès. Nous avons 904 patients qui sont soit dit déclarés guéris, mais en fait, c'est charge virale indétectable par la PCR. Et nous avons 13 régions sanitaires au Burkina Faso, couplées aux régions administratives. Et des 13 régions sanitaires, nous avons 6 régions qui sont toujours touchées avec 26 districts. Des activités ont été mises en place dès le début de l'infection. Nous avons eu à faire sous l'accompagnement quotidien de l'OMS Burkina Faso et notre plan de riposte avant l'arrivée des 2 cas. Nous avons fait un plan de riposte qui était minimaliste, validé dès le 7 mars et le 9 mars, nous devions rencontrer les premiers cas. Donc, dans le plan, sous l'accompagnement et les directives déjà diffusées dès les premiers cas par l'OMS, nous avons pu également faire des directives locales sur la prévention et le contrôle de l'infection que nous avons diffusées aux agents de santé et à tous ceux qui nous accompagnaient dans cette riposte. Nous avons eu des sessions de formation grâce à l'appui des partenaires que je ne vais pas citer ici parce qu'ils sont très nombreux, mais l'OMS a joué un grand rôle en termes de partenaires financiers, en termes de partenaires de conseils et de partenaires à tout moment. Et Madame Moeti, docteur Moeti, vous vous souvenez, il y a des moments, je vous appelais même le week-end pour vous demander, nous avons tel besoin, tel besoin. Bref, ces agents de santé ont été très, très rapidement formés quant à la prévention et au contrôle de l'infection. Nous avons mis en place un système de surveillance des agents de santé qui ont été infectés. Il faut souligner que la première responsable infectiologue du centre que nous avons retenu comme un tri a été infectée dès les premiers moments. Nous ne savions pas, personne ne savait. Nous avons utilisé les épis, mais la maladie était déjà là. Parce que, comme je vous l'ai dit, dès fin février, dès les premiers cas, nous avons eu des réunions en présentiel tel que présenté ici, mais à l'époque sans masque. Et il y a beaucoup d'agents qui ont été contaminés au sein du ministère. Il y a beaucoup de diplomates qui nous ont accompagnés, qui ont été contaminés au sein du ministère de la Santé, sans compter ceux qui ont été contaminés dans les structures de prise en charge. Et pour lutter contre et arrêter cette hécatombe, j'allais dire, de contagion des agents de santé, nous avons non seulement diffusé, élaboré et diffusé les directives, nous avons formé les agents de santé, mais nous avons mis en place des centres de tri dans les formations sanitaires. Parce que si on ne fait pas le tri dès l'entrée, les malades même qui sont dans les centres de formation peuvent se trouver infectés. Voilà des exemples de centres de tri avec des prélèvements quand le malade présentait des signes. Nous avons réquisitionné dès fin mars un hôpital pour permettre à tous les patients de pouvoir avoir toutes les commodités et de traitement possibles. Et ce centre, c'était un CHU parce que nous avons perdu dès les premiers temps.
Dr. Legu, allow me to come in and say you're raising some very good and important questions, which we'd like to deal with a little further, especially the issue of training. There are already questions around this line. So allow me, if you can, to please invite the Minister of Health of Sierra Leone to please join us, Dr. Alpha Wari, to talk a little bit more about their experience. And of course, we'll give everybody an opportunity. And if I could just ask the panelists to truncate their speech as best they can to about 3 minutes at the very most, so that we can allow more time for question and answers. It's over to you, Dr. Wari.
Tout à fait. Il n'y a pas de souci.
Let me first of all confirm that indeed you could hear me.
Yes, we can hear you, Dr. Wari. You can go ahead.
Good morning, Director, Regional Director, and my sister from Burkina Faso, and other ministers. This indeed is an opportunity for us to look at how we have been able to manage in our countries, most with regards to healthcare workers. You know, a country like Sierra Leone that was exposed to Ebola in 2014 or so, the state of preparedness was a bit heightened. The level of fear was less. We were in a position, therefore, to start point of entry assessment and of people coming in very early in March. That state of preparedness was even clearly more demonstrated with regards to the number of molecular biologists that we had to handle laboratory work. The PCR test, which proved quite difficult in most places, we were able to set up 3 labs in March before even the first incident in the country. That was scaled up to 5 labs within April. Also with regards to case management, we were lucky to have been requested by Brazzaville, WHO, to send 3 doctors out before the first incidents in this country, and they acted as training of trainers for most of the other healthcare workers. So there was a level of, you never ever prepared completely, but there was a level of confidence that when it arrived in Sierra Leone, we will know how to handle it at the early stages. But even that preparedness did not prevent the fact that healthcare workers were the very first to start to get affected by the disease. It so happens that whilst treatment centers were in readiness, whilst treatment centers had enough PPEs, but this was not so in the other hospitals. This was not so in other health facilities. So a non-COVID designated hospital, the PCMH, got exposed, the doctor got exposed, several of the nurses got exposed, and that hospital was even closed for a period of time. So we have not been able to get as much of the confidence that we thought we had because of the Ebola in starting the process. But our case fatality management has been great in the sense that of the 1,711 that were infected by 20th March, our case, the recovery rate is something like 72%. The recovery rate has been very good. The case fatality has been, well, low, I would say, a 3.8%. But within that period, healthcare workers have been exposed a bit more. We had 163 already healthcare workers, which indicates about 9.4% of healthcare workers have been affected. But what I want us to note in Sierra Leone is that this infection rate is not so much in the treatment center, which one would expect, but in other facilities outside of the treatment. That is where we had this issue. So it is clear to us that we have to step up with social distancing, step up with the use of face masks. But as has been expressed by the regional director, now it's become a bit difficult to be able to spread the limited amount of the PPEs that you have, not only to treatment centers, but to all other facilities. Because it's now clear that you might be getting higher infection in all other facilities. Let me say, as a country, we thought people will feel a bit more confident if they are insured. If they are insured. We have been working on that for the last 3 to 4 months. And on Tuesday, I think that should be the 28th of July, His Excellency the President is going to launch a national insurance scheme for COVID for all healthcare workers. That has created such a settling effect. That has created a lot of confidence in the service providers. Indeed, we've lost 3 doctors. We've lost 3 other facilities, 2 CHOs and 1 nurse. We've lost 6 already. But the hue and cry that we had in Ebola, the hate factor that developed in Ebola has dampened significantly now, because the insurance package reflects when you're exposed to the disease and get well, what you will get. When you're exposed to the disease but feel maimed, difficult to come up, what you will get. When you lose your life, what the family will get as well. And we hope on Tuesday we'll be able to launch that and let the public know. In particular, let me say this, Africa, we should be thankful that indeed the extent of scourge that they thought this pandemic would cause us, we have not been in a position to experience it. We should be thankful that indeed our scientists are in a way to be able to get to full grasp with the use of the PCR test quite early. We should be thankful that our turnover rate for results, we send out results every 24 hours, and we are told the Western world it could be a week or more. So there is a lot to be done. There is a lot to be done, but I think there is a lot we can also share from each other that will give us the confidence that we are on the right path. I thank you.
Thank you so much. We really do appreciate that. And it's quite encouraging to hear about the insurance scheme that you say the president in your country, Sierra Leone, will launch. But now it's important that we hear from the healthcare workers themselves to hear in their own voice what the challenges are. Dr. Jemima Dennis Antwi is international maternal health and midwifery specialist. She joins us from Accra in Ghana. She'll tell us what the West African experience, especially with regards to healthcare workers, is in her country. Shall I hand over to you, Dr. Antwi?
Thank you very much. Good day to my esteemed panelists, the organizers, the media persons, and fellow colleagues. And hello, Professor Wuri. I just returned from Sierra Leone in March, where I've been working for 1.5 years with UNFPA. So, Prof, it's good to see you again, and thanks for the opportunity to work with your team. Let me first of all thank WHO Brazzaville and the organizers for their kind invitation for me to present on what healthcare workers need to do to protect themselves from COVID-19. And I bring my perspective as a policy health system strengthening person, policy development person, and also somebody involved in several years of capacity building, and also work with frontline workers. Following on from previous speakers, currently there is paucity of published information on the true magnitude of health professionals' infectivity, as this is highly guarded by countries. However, there are documentations indicating countries such as my own country, Ghana, Kenya, Nigeria, Togo, Namibia, and Zimbabwe having reported cases of health worker infestation. And I'm glad that Sierra Leone and Burkina Faso have also indicated that they have also had their share. Coming to my own country, Ghana, I am happy to say that for my country, they have published information. Ghana, through the recent press briefings by the health professional unions and the Director General of the Ghana Health Service, report of about 2,065 cases of health professional infectivity. Of these, I'm proud to say that 91% fully recovered. There have been 9 deaths, including 4 doctors, 1 nurse, 3 lab techs, pharmacists, and then out of which we have the nurses and midwives have the majority of infectivity. Over 410 nurses and midwives have been affected in Ghana on duty, on the side of duty. And this is because, of course, we are designated to serve our patients 24/7. The increasing numbers of infectivity among health professionals, coupled with limited or lack of consistent supply of resources, as have been stated, result in refusal to attend to patients, psychological stress to self and families, constant threats of industrial actions among many in countries. These, as we all know, have serious implications for quality care, especially reproductive, maternal, newborn, child and adolescent care. And we know of rising surge of domestic violence in countries because of this the COVID situation, and also the fact that there will be limited people to care for the chronically ill. There is actually the need for urgent action to keep our health professionals alive to provide the care that they are trained to provide. As health workers, what we need to do to protect ourselves, our patients, and our families from infections fall into 2 folds. What we as individuals need to act on for ourselves and our families to be protected, and secondly, what we need to do for a collective safety and care of our patients. Individually, we need to continue to get ourselves educated and to build our competencies around COVID-19 and adhering to infection prevention protocols at all levels of care. As Professor Ruri stated, the infection is not from the treatment sites, because there everybody is well groomed and they are very much aware. The infection is happening on our general wards and in the community, where we assume people working into the health facilities are COVID-free. We need to have our regular exercises and continually wash our hands, following all procedures. We need to have our adequate rest with good ventilation. We need to look at gargling our salt solutions in order that we can clear our throats and keep them warm and refreshed. Steep inhalation has been proven to be good, and which we need to continually do. And of course, looking at nutrition supplementation in order to boost our immunity so that even if we come across a virus, we can fight it. And we all know that majority of cases are asymptomatic, and we have a lot of people who pass through and not develop the disease because of the immunity.
And
collectively, yeah.
Just stop you. I apologize, but we are running out of time because this is a question and answer session for the journalists as well.
Sure.
A number of questions we'd like to ask that, but some very valuable information coming out of you and the Ghana experience. So allow me then to just say, colleagues, we're going to move into the Q&A session. I'd like to reiterate that please, do indicate who you are and who you represent as in the media organization or entity. So the first question we've got, I'll pass this on to Dr. Mwiti. It's from Pamela Mawanda, who is in Uganda. She's at Uganda Radio Network. And she's asking how many healthcare workers have been infected with COVID-19 and how many have succumbed to the disease. I know earlier on you did mention a figure of 10,000 healthcare workers who've been affected, Dr. Muti, but perhaps if you could expand a little bit more on the deaths and also, if it's possible, has there been a categorization of where these infections have occurred and why?
Okay, thank you very much for that question. As I said, we have had 10,000 healthcare workers. At least we're aware of 10,000 healthcare workers having been infected in the region from the information that we are getting daily from our country teams through having come from the ministries of health. We are looking, and I think one of the ministers said, the minister from Burkina Faso said that they've established surveillance of healthcare workers system. We're looking to work with countries to improve the collection of data on healthcare workers so that we can be aware not only of those who have been infected, but also of those who have been who have lost their lives and the different categories of healthcare workers that have been affected. So I'm not able to give precise numbers and data, but just to say, as was already indicated by Ms. Antwi, that the majority of those who have been infected have been nurses, but we have had all categories of healthcare workers, doctors, laboratory technicians, and even some of the people who are providing ancillary support in healthcare settings infected. So we are looking at improving the collection of data on healthcare workers so we can determine also to what extent is the infection happening at work, and of course try to make sure that we prevent, or they are informed to prevent, limit transmission when they're at home. So I'm not able to provide more precise information now, except to say that we are working at improving the surveillance of this problem among healthcare workers.
Dr. Mwiti, to say, I know the next question from Carrie Ann pretty much repeats what you've said, that you're unable to give data, but I think if you'll allow me to read it, because it can also be answered by you, Dr. Logu, just on your side from Burkina Faso, how many healthcare workers have died, and if you're aware of any efforts by countries to recruit health workers from the diaspora to help strengthen the system. So Dr. Mwiti, if you can very briefly, and then we'll move on to you, Dr. Lugu, to answer that question as well.
Okay, and I mean, I think the question is asking...
Et merci pour ceux qui ont pris la parole avant moi. Au Burkina Faso, nous dénombrons à ce jour 111 000 agents de santé qui ont été infectés. Et la plupart des infections, soit la moitié, sont intervenues au mois de mars, au moment où les agents n'étaient pas bien formés. Et nous avons eu 50 cas sur 111. Et au mois d'avril, nous avons eu 46 cas. Il y a eu, comme les prédécesseurs l'ont dit, des médecins et des infirmiers et toutes catégories confondues. Et il y a eu des agents de santé qui sont venus, des experts qui sont venus nous appuyer, des partenaires techniques et financiers. Et parmi eux, il y a eu des cas d'infection également. Mais heureusement, aucun des agents de santé infectés n'a perdu la vie. Je pense que j'ai répondu plus ou moins aux questions qui ont été posées. La majorité des agents infectés avaient entre 25 et 39 ans. Donc, c'est des jeunes qui se sont engagés dès les premiers moments à nous accompagner. Très tôt, nous avons veillé à ce que ces agents de santé soient bien protégés. Avec l'OMS, au départ, on leur donnait des épis et après, ça a évolué vers les Kazakhs. En tout cas, la protection des agents de santé a toujours été au centre de toutes nos activités. Merci pour la question.
Okay. Tsepiso, can I just
Yes,
say a
please.
word about diaspora, perhaps?
Yes, please go ahead.
Yeah, I mean, I think that I'm not aware of any major initiatives to have healthcare workers from the diaspora coming back to Africa to work in the countries. Because at the same time as the pandemic took off in the region, the country is pretty much locked down. So I think that international travel would have been a challenge. What did happen though, because of the way of working virtually, we had a huge involvement of African diaspora healthcare experts of different types in the training that has been taking place of different disciplines, working with WHO, with the Africa CDC, with other partners. So we can say that the diaspora has been very significantly involved in helping to disseminate information, help with training, improving skills. They've also networked with their colleagues, friends abroad, and mobilized really support for the response in the region. So I would say that we've very much appreciated the involvement of the African diaspora of health professionals, and it's something that we're looking forward to continuing working with the government's contribution.
Thank you so much for that, Dr. Moot. We have questions coming in, colleagues. I'm sure, as you know, it's first come, first serve. So if you had used the question and answer session before, then we'll be able to ask your question a lot sooner. We do have this next question from Ajima David Tiombano, who is from Le Chaîne Africain. So it's in French, but the English translation I've been given is that the increase in corona numbers are obviously very worrying, especially as restrictions throughout the continent are relaxed. Should we fear the worst for our countries? And perhaps let me give Dr. Worry an opportunity to answer this. I mean, you've spoken about your case fatality management and the increasing number of recoveries. Would you like to perhaps take that question and answer it?
Thank you very much. Let me first of all say that indeed the numbers are coming up. However, the rate of increase is not alarming for most countries to be able to manage. When you compare the numbers you have as against those that have recovered. In Sierra Leone, for example, I mentioned as of the 20th of this month, one is dealing with 1,711 cases, and you have a recovery rate of over 72%. That in itself is manageable, I think. And the rate of infection as the period goes seems to be dropping. I use the word seem because there have not been full-fledged statistical analysis to actually confirm what part of the epidemiological curve we are in. But the rate of exposure as compared to the number of tests done per day seems to be less and less. That is one major issue I think one should consider. The other level now is the fact that laboratories have now been increasing in number. In Sierra Leone, there's a major skew when we started, in which most of the labs are in western area, the city. Now we have one in the eastern part of the country, and we are putting together another in the northern part of the country, which means the turnover time to get the results is getting better. So the level of anxiety has dropped. The other issue was we initially focused on every contact, primary contacts, to be put on quarantine, where they are monitored, they are assessed for 14 days. That is a very expensive exercise. And we note, however, although we've kept it so for most instances, but the numbers now on mandatory quarantine is getting smaller and smaller. We now have less than 700 in mandatory quarantine. We also now have the confidence for people that may be affected, most of them asymptomatics anyway, but have homes that are reasonable, that you can ask them to go on self-isolation or self-quarantine. That number is getting better and better, and we've been able to send people on psychosocial service, which is a key thing now. I think the level of anxiety, I don't want to say the mental position, but you need people of psychosocial background to be able to create some understanding, some settling. So a long and short of it, I see most African countries, the numbers are going up, yes, but the numbers that have been treated is also on the increase. So the confidence by each country believing that they can manage the situation is getting better and better. And the more we get exposed our people to psychosocial analysis or psychosocial input when they are sick, when they are in quarantine, the more we would have greater confidence building. I thank you.
All right. Thank you so much, Dr. Worry. There are quite a number of questions that are coming through, and perhaps if I could just conjoin some of them, because there's a question about from Damien about the main drivers of lack of PPE and testing, whether or not it is a funding, logistics, or just a global shortage. And I see there's the same question coming through from Olabisi Adesina of alternativeafrica.com, who's also saying, is the lack or inadequate use of PPE causing an increase in the spread of COVID-19 among healthcare workers and support? So if I could just get Dr. Antwi for you to give a response, and Dr. Mwit will also come to you if you could, if you'd like to respond to this. Dr. Antwi, just please
unmute my, yes. Thank you very much. The issue of testing. Yes, I believe that, speaking from my country, we have about 5 major testing sites, but the main testing site is in Accra, Noguchi Memorial Institute for medical research. We have one in Kumasi, and then also we have other satellite stations. But in terms of collection of samples, we have so many sites that collect samples and then put them in these sites, which can then run the test. And I think that in terms of personnel, we have excellent personnel to do the testing and everything. The issue sometimes happens with delays in turning around the results. And sometimes that can affect the extent to which we are able to determine whether somebody is a true case for COVID in order that the right referral will be done. And this tends to expose health workers to the infection. Another challenge that we tend to have with the issue of testing is that when reagents run out, as you know, most of these reagents are imported. And with all the shutdown of most of our airports, it means that special arrangements need to be made in order that we can import these reagents and testing kits. So that sometimes do affect the rate of testing and also the rate at which results can be released. And in a sense, it means then that we may not get the results as quickly as we expect them to, and it has its own repercussions on the quality of care that we would love to give. Nonetheless, I think that in terms of the systems that our country, Ghana, has put in place, we have a very robust system. In the area of PPEs, as you know, PPEs, I think governments have been doing their best. I'm not speaking specifically for governments, but I know that, for example, in my country, they've been sending in the PPEs. What happens is that we cannot give the full package of PPE to every health worker. And therefore, what is done is that they look at your placement within the health facility, and that determines the type of PPE that you must get. The issue is that because these PPEs are disposable, the turnover is very high. And therefore, there is the need for continual request and the continual restocking. If healthcare systems are not able to keep updates with trying to keep their stock levels, then there are delays, and then that can affect the time within which they are able to get the stock. And then also systems that are being put in place by some health facilities is to make sure that each health worker actually signs for their PPEs so that they can actually have a database of who is receiving, who is not receiving, so that they can act appropriately. But let me talk about one challenge that we tend to have, and that is for our health workers who are in the general health facilities and not in the treatment centers. There you are not expected to wear your full spectrum of PPEs. And patients may come in not necessarily exhibiting the signs and symptoms of COVID. So they are treated as normal patients. And then in the course of their management, then the COVID symptoms show up. And in that time, a lot of health workers may have already been exposed. And this has been a very big challenge for health workers. And I believe that it is time for countries to begin to say that every patient that comes in is a potential COVID patient, and therefore we must put on the basic requirement of PPE so that we can manage effectively whilst we wait for the results of testing. Thank you.
Thank you so much, Dr. Antwi. So let me just go to this question from Beatrice of AFP. So she writes, the number of confirmed cases of COVID-19 in Madagascar has been increasing significantly in the last few days. The main hospitals in the capital are overwhelmed. Have you received a request from the Malagasy Ministry of Health for assistance? Have you received negative or positive reactions from countries using the COVID organics? So, Dr. Michelle, yeah, if I could please ask you to step in and answer that question.
Yeah, thank you very much. The situation indeed in Madagascar is a bit changing upward. The number of cases has increased during the last 2 weeks. We have 2,000 cases. We are working closely with them. We are interacting with them to fill some of the critical gap, mainly increasing capacity for treatment, some of the medicine to use in intensive care. We have, with all the partners also, support has been provided to scale up the treatment capacity with a treatment center of 400 beds that has been now operationalized. So we are working closely with them and also mobilizing different partners to move forward. About the COVID organics, we are also working, a protocols has been established, and the both team, WHO and national teams are working to push forward the clinical trial related to the COVID organics. So our collaboration is there, and we are monitoring the situation that is changing quite fast. Okay.
Okay, thank you so much. So this question then is from Kemo Cam on Sierra Leone. Let me start reading that first because there are quite a few of them. So this question says, even before COVID-19, Sierra Leone was struggling to restore public trust in health facilities. With the pandemic, what little gain that was registered has been reversed. As a handful of independent studies have indicated, has the government itself got any data to back or disprove this? And another question for the minister is, even before COVID-19, Sierra Leone, okay, so it's the same question. So if I could just get you to answer that. Minister?
Oh, yes, thank you very much. Indeed, the presenter is right that Sierra Leone was struggling to restore public trust. However, if you relate it to the Ebola period, there were major gains made in the 3 years for people to feel confident to start to access facilities. I think the trust there was mainly due to the fact that going to these facilities, you may have a problem with either meeting personnel or providing the basic drug services that you require. May I say, in the last year, we have established by an act of parliament an institution called the National Medical Supply Agency, NMSA. That agency has made a major improvement in taking, for example, drugs and medical supplies to the last mile. And that is one major confidence and trust. The other issue, which was mentioned even by the minister from Burkina Faso, is the establishment of triage in most of these facilities. And therefore, the separation of critical and non-critical cases starts early, and treatment also starts quite early. As a country, we were giving free drugs, mainly through defeat. But the last 2 years, the government has now started to pay for a percentage of the drugs under this free healthcare initiative. That payment has also strengthened the monitoring and evaluation of these items for the last. Another confidence building one, I must say, is the creation of special baby care units that we now have. Previously, neonates do not stand a chance. Our under 5 mortality rate, it was high. Infant mortality rate is high. A key thing to just look at is the 2013 health demographic survey as against the 2019 health demographic survey. You would all look at your statistics. You would look at maternal mortality was quoted mainly as 1,165 for 100,000 lives. Well, that was the least in Africa. But if you look at the recently published 2019 HDS, you're talking about 717 deaths in 100,000 lives. It is still low. It is still weak. However, it starts to give you trend. It starts to give you that there are major gains being made. So I want to say yes, trust is weak, but that trust is improving on a daily basis. And although COVID initially started with fear and doubts, but I mentioned earlier, management of COVID in Sierra Leone has been better using the Ebola experience. And therefore, that fear has waned within a short period of time. Yes, please.
Thank you. I'm going to have to move on. I'm sorry. If I could just also ask the panelists to be as brief as possible with answering the questions so that we can get as many in as possible. There's a question here seeking clarification, Minister Logu, on, it's from Nofu Kindo from Burkina 25. And what they're saying is that in your earlier answer, the impression they have is that you gave a figure of 111,000 in terms of the infected healthcare workers. But the question is, how is that possible if the infection rate is at 1,000 at this at this stage. Dr. Lagu, would you like to answer that, please? Dr. Lagu?
J'ai pas, merci bien, j'ai pas très bien compris la question. Et le taux d'infection inférieur à 1000, le taux d'infection des agents de santé ou bien?
What it's saying is that there seems to be a
la
contradiction, Dr. Lagu. You gave a figure of 111,000 according to the question, the person who was asking the question, in the number of infected healthcare workers. And they're possible because you only have 1,000.
D'accord, d'accord, je comprends bien. Mais avant de répondre à cette question, la question antérieure, j'avais pas totalement répondu, mais heureusement que Dr. Moiti l'a fait à ma place. C'est vrai, nous avons appelé tout le monde pour nous accompagner, dont des Burkinabés, agents de santé de la diaspora, qui ont constitué des équipes qui ont travaillé avec nous via Internet pour nous accompagner, notamment dans la prévention et la surveillance. C'est vrai, je pense que je ne me suis pas fait très bien comprendre. Nous avons à ce jour, depuis le 9 mars jusqu'à ce jour, environ 1068 personnes infectées dans la population générale. Et de ces 1068 personnes infectées, nous avons 111 agents de santé infectés. Donc, je ne pense pas qu'il y ait une incohérence de chiffres et peut-être que c'est moi qui ai mal posé le problème. Et de ces 111 personnes infectées, nous avons 95 personnes, agents de santé, qui l'ont été au mois de mars et au mois d'avril, au moment où la formation n'avait pas été efficace. Je vous remercie. Je pense que j'ai répondu à la question.
Okay, so this next question, Dr. Mwedi, it's to you. It's from Tanzania. It says the central government has not released the information about COVID-19 infections since April 29, and the president declared Tanzania free of COVID-19. What is the reaction of the WHO for the declaration? And do you think the country is safe for traveling? And okay, so this question is there anybody who can talk with the Tanzanian government about the ongoing coronavirus? So obviously that would be to you. Dr. Mwetu.
Yes, thank you very much. So we have received since the date cited in April, reports of alerts which have been, if you like, eliminated by the Tanzanian Ministry of Health, but we have not received any reports of positive cases. As we've indicated in the past, however, we know that from cross-border information shared with WHO, for example, from Uganda, where they have a quite robust program of testing at the border, people who are traveling into the country, they found quite a significant number of particularly truck drivers from neighboring countries who are infected, including from Tanzania. So we have provided this information about the number of infected Tanzanian travelers, truck drivers discovered on testing in Uganda to the Tanzanian government as well as to the other countries. We have been in touch with the Tanzanian government requesting them to take into account this information and advising that it then needs to be incorporated into the reporting to WHO. So I have written to the government, to the Ministry of Health on this recently, and we are following up and hope to have a discussion with them to see in what way we can assist in relation to interpreting this information of tests that are carried out in another country so that it's possible to have it incorporated into the reporting of the country. Our country team is very much together with other partners engaged in a dialogue constantly in offering support to the government. And I believe that in the preparedness activities, they're very actively engaged with the Tanzanian government. What we can do is to encourage the leveraging of this information that might have been acquired from somewhere else into a review of the national situation and a sharing of information with WHO, and particularly then working with us and other partners to make sure that the public health interventions that are necessary are strengthened in Tanzania.
Dr. Moeti, thank you very much. Marcia, I know you asked this question from Health E-News about traditional medicine remedies. I hope that the answer that was given previously assisted you in getting an answer to that. We've got a question now from Shani Reddy, rather, to Dr. Worry. She's saying, Shani Reddy is from the Daily Maverick in South Africa, saying, are healthcare workers regularly tested in Sierra Leone? And if they are not showing symptoms, if some are completely asymptomatic, would they not be spreading the virus unknowingly? We have had doctors who were asymptomatic and give the virus to their spouses. So you mentioned earlier on about a 72% recovery rate, Dr. Worry. So could you just expand a little bit more on how you monitor that?
Well, thank you so much. Let me say the world at large are still learning about so many things about this virus. And as you said, people could be exposed to it, but they are asymptomatic and indeed could spread. As we go every day, we try and pick up more preventive modes, more modes of protecting the healthcare worker, and more modes of protecting the patient from the healthcare worker. So healthcare workers in Sierra Leone are, I won't say regularly being tested. You know, this thing is all about 3-4 months only. But testing of healthcare workers is encouraged. Although encouraged, we have not made it mandatory. The reason being, most workers don't stay in their own houses, in their own homes. They are in rented properties. There is a level of stigmatization the moment it is viewed that you are exposed to the disease. But among those tested, the infectivity rate is not higher than the national prevalence as we are now seeing. We've only just recently been exposed to what we call community transmission. So we've only just recently started to actually open out the tests to institutions. For example, we just recently done the military, parts of the military, some of the military. We just recently started doing the police. Schools are about to open. We are supposed to do teachers, even students would be tested. Along with that, healthcare workers would indeed be tested. But we don't want to target healthcare workers because that could also target them for stigmatization at this instant. But the country as a whole, what is being reflected is not a high infectivity rate. What we are afraid is now we have, for economic gains, we are about to open the ports, airports, seaports, and we are uncertain what would be the outcome of that, even though we are putting all the precautionary steps in place.
Okay, thank you so much, Dr. Worry. Because we are nearing the end of the online briefing, I'd like to ask all of the speakers, if you can, very briefly, just share your thoughts on the presentations that you've made and obviously the country experiences that have been shared. But I'd like to start with you, Dr. Antwi. So the way forward, especially for healthcare workers, I saw a report suggesting that there may even be a shortage of medication because some countries who have greater wealth are buying in bulk. Is this something that the poorer countries should be concerned about? Just from a health worker perspective, do you feel that there are enough systems in place to guarantee your safety as you are on the front lines? You are the first responders, after all. I'm asking Dr. Antwi, Dr. Worry.
Oh. So, well, if I just make a short intervention and if that we are far from having all what it takes to be able to protect the healthcare worker. We have recognized that whilst we focus on treatment centers, every patient that comes is a potential individual that could be infective. And therefore, basic PPEs should be with all healthcare workers wherever you are. We also think that rates of access of medication is weak. Most of us were buying through international agencies, UNICEF, for example, because of the competing needs as at now. Even when you pay for it, it will take you a couple of months before you receive what. So there is a weakness not only in availability of PPE, there is also weakness with drug availability. This is a pandemic globally. And those where you should run to and get things, they also require to upkeep everything that they do have. The difficulty is around, or it's a bit more difficult for countries like ours that are poor, wherein you cannot just walk into a shop and pay. You have to buy through international agencies, and their own international stores, their international procurement entities also reflect the weaknesses. I thank you.
All right, so thank you for that, Dr. Wari. Dr. Antwi, let's hear from you. What innovations can we bring forth?
Okay, so in terms of innovation, I believe that as health workers and then also as governments, there are certain things that governments can do to help us as health workers. At the level of the facilities, I think that there is definitely the need for continual education and prompting of health workers. The tendency to be relaxed about the situation and to assume that, oh, this is just one of the infections is very high, and therefore continuous sensitization is very critical. Some governments or some facilities try to provide supplementation to staff, but this is not regular, and staff need to buy their own supplementation in order to keep healthy. Some facilities, again, try to provide at least one meal a day for staff so that they don't have to go out to look for food. If this can be sustained, at least we know that staff are having good food. For example, in my country, we have the designated COVID treatment centers. Staff are provided with good food and also patients as well. So that tends to limit sort of the stress on themselves in trying to get access to food. And I think that this is good. Another thing also is that when there is contact tracing and the fact that a staff is identified to have been exposed, quickly those staff who have been exposed are all mandated to test for free, and government pays for those services. And then also there have been certain motivation packages that have been put in place to encourage staff in order to stay at work. I think that governments need to continue this and also to continue to look at the quality improvement structures. There is the need for infrastructural development that would enable us have access to good quality facilities to limit the infection. You have doctors and nurses sitting in the same room with patients who are COVID because they don't have anywhere to sit. So you're exposed to the virus 24/7. But if there were spare rooms or doctor's room or nurse's room, you could go in there intermittently, provide care, and then retreat. These are some of the challenges that we have, and we believe that innovation should critically look at this as a way forward.
Well, thank you so much, Dr. Antwi. Let's go to Dr. Logu now to just get a final word from you. Just what do you anticipate will be your greatest challenge over the next couple of weeks? Some countries like South Africa, as you would have seen, that they're facing a peak. Are you prepared for that? Are your health systems strong enough? Dr. Logu? Dr. Logu, if I could please ask you to unmute yourself.
Je voudrais dire merci à tout le monde, réitérer mes remerciements aux organisateurs de cette session qui nous a permis de partager nos expériences. Il faut dire qu'au Burkina Faso, je me réjouis que nous sommes à peu près au même niveau que les autres, sinon un peu plus avancés, parce qu'en matière de prise en charge des agents de santé, nous avons obtenu du gouvernement qu'on puisse leur donner une motivation. Et donc, nos perspectives, c'est continuer à les former. Nous sommes en train de passer à la routine. Nous avions dès le départ élaboré des directives pour les protections des agents de santé en fonction de leur niveau d'intervention auprès des patients. Nous employons à vérifier que ces directives soient respectées au niveau des hôpitaux, que les centres de soins soient fonctionnels et que la formation en ce qui concerne la prévention et le contrôle de l'infection soit effective. Étant donné que nous nous acheminons vers les ouvertures des frontières, nous avons fait une dévolution, des stratégies de dévolution de la lutte, de la riposte contre la COVID à toutes les formations sanitaires du pays, parce qu'on ne sait pas par quelle frontière ça peut rentrer. Et les gens ont été formés, des stratégies ont été mises en place et nous travaillons à acquérir du matériel de protection pour tous les agents de santé en fonction de leur niveau. Et il y a un suivi électronique qui se fait pour pouvoir avoir les données au jour le jour grâce à l'accompagnement des partenaires dont l'OMS. Nous pensons que l'avenir qui s'annonce va être meilleur qu'au début de l'infection, d'autant plus que les uns et les autres ont déjà été formés et que nous travaillons à faire passer la COVID-19 au système de santé tout en améliorant les infrastructures pour que, comme l'a dit Jemina, les agents de santé ne restent pas trop au contact avec les malades. Et dès le départ, nous l'avions compris que nous avions déjà élaboré un hall dans l'hôpital qui a été un hall de surveillance dans l'hôpital qui a été réquisitionné avec un bureau de repos et de détente pour les agents de santé. Nous allons renforcer nos stratégies de départ. Je vous remercie.
Well, thank you so much, Dr. Lagu. Let me end with you, Dr. Muedi. There's a question, I think, which bears asking from Rhoda Odiamo from BBC, talking about, I know you mentioned that South Africa has 2/3 of the healthcare worker infections. Are there any countries that are worth mentioning who are grappling with this? And are there countries that we can look to in how they've reduced their infection rate, like Cote d'Ivoire, for instance, on improving the lot of the rest of the continent?
Yes, thank you. I think after South Africa, the next group of countries where we have seen, especially after the easing of the lockdown started, cases ticking up again include countries like Algeria, like Kenya, Ghana to some extent, Cote d'Ivoire, Cameroon, and Zambia, as I mentioned. I mean, the numbers are very different from the situation in South Africa. For example, Nigeria so far has cumulative 4,000 cases as compared to 85,000 in South Africa. But I mean, I think there are common lessons to learn here in terms of how to ensure that the public health measures are up to speed, decentralized, as was said, with a concentration on what might be called hotspots, the areas, the localities where the rate of increase is the greatest. And of course, the biggest challenges are in cities, in places where the population density is high and where physical distancing is quite difficult. We've seen some countries, Cote d'Ivoire is an example, really use the data to adjust the response, if you like, lockdown locally where it's necessary to enable life to continue and the economy to open up in other localities. I think that one of the most important things to do is to really enable people to grapple with the challenging circumstances and play their role in limiting the spread. So it's been mentioned, the use of masks. I see, even in the town where I live, masks are available, but people have started to relax and are more and more wearing them around the chin, below the nose. There needs to be a very robust support, monitoring, follow-up, reminder process so people keep the masks up all the time, including the physical distancing. We need to find multiple channels so people can be reminded by an SMS in their phone, are you keeping your distance if you're out at the market? What are you doing? So this kind of grassroots-based interactive communication with people, because they will have to play a key role, is what, in my view, needs additional emphasis. And it might mean having more and more people out there. Some people have called them armies, volunteers, looking, monitoring what's happening, of course, collecting data as well, and really responding, enabling people to be reminded, to be enabled, distributing masks to those who can't afford to buy their own masks, for example, making sure that people have water points where they can do their hand washing, distributing the sanitizers, and here the international community support will be needed. I think these are some of the things that need emphasis now. Thank you.
Thank you so much, Dr. Moeti, Dr. Matshidiso Moeti, the WHO Regional Director for Africa. Thank you so much as well to the Honorable Dr. Leonie Claudine Logu, who's the Minister of Health in Burkina Faso, Dr. Fawari, Minister of Health and Population and Sierra Leone, speaking to us from Freetown. And thank you very much, Dr. Jemima Dennis Antwi of the International Maternal Health and Midwifery Specialist, speaking to us from Accra, Ghana. Colleagues, as Dr. Moeti said, it's one health worker too many, and I think it's one citizen too many if we're not adhering to the protocols. I do want to remind you, I see some of you, the questions that you're asking have to do with vaccines, etc., etc. APA Group has been very diligent in documenting these press briefings, so if you could just go to their website and you'll find some of your answers there. Thank you so much for joining us, and hoping you all stay well and healthy. That's it from us for today. Goodbye.
Thank you.
Thank you. Thank you all. It's great to have been invited. All the best. Bye-bye.
Thank you.
Au revoir.
Thank
Au
you.
revoir tout le monde et bonne journée. Dr.
Bye.
Waro, bonne journée. Dr. Moeti,
Madam
tout le
Claudine,
monde,
it's
bonne
great
journée.
to
Au
hear you.
revoir.
It's been a long time.
Long time too. Long time too. Thank you. Bye. Merci. Je regarde ceux qui ont suivi. Juste